Assalamu alaikum and welcome to another recorded lecture. This time we're going to discuss an approach to the management of vaginal discharge. Vaginal discharge is a common gynecological symptom and a common reason for presenting to the gynecology office or even a GP office. And we're going to look at different ways how to kind of manage this in different scenarios. First, we briefly go over the causes of vaginal discharge. We have discussed them before, but we'll just briefly repeat them. We want to understand the practice, to practice a systematic approach to such a workup, and finally discuss some of the implications for women. So it's a common problem, as I said before. It's about 30 to 50% of gynecological office visits. It has different causes according to age group, but also within age groups, of course, there are different causes, and there might be associated symptoms which are important to explore, such as itching, pruritus, irritation or erythema, dysuria, soreness or pain, and dyspareunia. So let us briefly go over the causes of vaginal discharge. It is important to recognize that a number of vaginal discharge cases are physiological. So there's nearly always a physiological discharge present, and this might change throughout the cycle, and also sometimes it might change with taking different forms of hormonal contraception. It might also change in pregnancy. So all of these might be reasons for women to notice a change and be concerned, while the discharge is actually physiological. It might be infectious. There might be some underlying allergic dermatitis. Sometimes lichen sclerosis can also be a cause of some vaginal irritation and problems, or vulval irritation and problems. Chemical vaginitis can be one cause, and this can begin with the use of female hygiene products. Sometimes you get non-infective vulvitis causing problems, and finally you have the genitourinary syndrome of the menopause that was previously called atrophic vaginitis, and this is really due to the lack of estrogen, which might change the vaginal flora and also change some discharge. So predisposing factors are also often present, and this might be the use of antibiotics, which might kind of lead and emphasize certain infective conditions. Sometimes a change in the alkaline, a change in the pH, the vaginal pH, which is usually acidic, a change to a more alkaline condition can be the cause. And this change in alkaline conditions can be caused by blood, sometimes by semen, so following intercourse or following menstruation. Poor hygiene can be a cause, but also overzealous hygiene practices can be a cause, where frequent douching and cleaning might actually change the vaginal flora and bring about some infectious changes. Pregnancy and diabetes are other predisposing factors. So it is important to have a systematic approach, and we've talked about this many times before, that in nearly every problem you face in medicine, it is best to practice a systematic approach. This includes a history, starting with a history, followed by an examination, followed by the necessary investigation, then management, counseling, and finally review. And review in this context of vaginal discharge is often important, because a number of these conditions are recurring, and you have to make sure that women do understand this, and that the treatment and management you apply actually works for this woman. So history includes, of course, symptoms, duration, the relation to the cycle. So you have to know LMP and regularity of cycle, as well as contraceptive history, odor, color, and amount of discharge can be helpful. You have to know the past medical history, and if this problem occurs for the first time or is kind of a recurrent problem, and if so, what other treatments have been tried prior to coming and attending the doctor now, because you will find that a number of women might have tried over-the-counter treatments that were kind of delivered to them by the pharmacist. Then following the history, an examination is important. You have to inspect the external genitalia, look for erythema, excoriations, and so on. A speculum examination will allow you to assess the cervix and also to assess the discharge, so you can look at the amount, color, odor, and so on. A pervaginal examination is also often indicated, as this allows you to see if there's an upper genital tract involvement, any adnexal problems, and the size of the uterus. This has to be followed by investigations, by management, counseling, and review. And we're going to talk about these different steps along while looking at cases, so we kind of have an opportunity to practice these steps. But before we look at the cases, I want you to think about the red flags for a minute, or less than a minute actually. So what are the red flags that you have to remember and keep in mind? So first of all, there's trichomonas vaginitis in children, which might be suggestive of sexual abuse. If a woman complains to you about fecal discharge, this is always a red flag, even if you cannot see the fecal discharge, as this might be a kind of suggesting there's a fistula. Fever and pelvic pain are red flags, and bloody discharge in postmenopausal women, of course, might suggest there might be an underlying endometrial carcinoma. So now let us look at and practice these kind of steps, and with looking at several cases. So a 24-year-old presents with an increase of vaginal discharge, causing her wetness and discomfort. So what are you going to do next? Yes, you're going to kind of elaborate the history a little bit. You can do this by asking, can you tell me more? What else is bothering you? Or you can, and if then you do not get all of your answers, you have to ask some specific questions. So she tells you then that she has a white discharge, some soreness and pruritus, which is not too bad, no odor, but she had this problem before, and at those times it always went away on its own. It recurred following menstruation this time. Then you have to do the examination, and on the examination of the external genitalia you see these typical picture with lacerations and satellite lesions. So what do you think this might be? It is, of course, vulvovaginal candidiasis. It is best treated with clotrimazole, a pessary, and cream. You might want to use a cream that also has a bit of hydrocortisone in it, especially if the skin is very red and sore. It can also be treated by fluconazole, which is given as a stud dose, a one-off dose, 150 milligrams one-off. In case of recurrence, it's always important to actually take swabs, as this frequent recurrences might point to the fact that you're not dealing with Candida albicans, but you're dealing with a different Candida species, such as Candida glabrata, and these are much more difficult to treat. It is important to explain to the patient that this is Candida as a commensal in the vagina. It only needs treatment if there are symptoms, but it might cause symptoms and kind of get kind of a growth spurt if if the vaginal flora changes, such as following menstruation, following antibiotic treatment, or when the vagina is hot and moist, like in hot and moist weather, or with kind of tight-fitting clothes. Recurrent vulvovaginal candidiasis is a annoying problem that can cause quite a bit of distress to women. It should be treated with a one-off dose of oral fluconazole, followed by a weekly dose of only 50 milligram fluconazole. It is important to check the liver function tests if you opt for longer-term treatment, as fluconazole might actually impact on the liver function. So, and then, as I said before, it is important to take swabs to make sure which Candida species you're dealing with. Another point I forgot to mention now is that in these cases, especially those with recurrent problems, it is very important to check to make review dates and follow-up appointments, put in place safety netting, so that you can give the patient, they know that they can always come back and see you again if things don't get better, if things get worse even, or so that you can then kind of look for other ways of treatment. A 36-year-old patient. So let us go to our next case. A 36-year-old woman this time complains of smelly, copious vaginal discharge. She had it before, but it went away on its own. But recently, she notices that this problem occurs more frequently and causes her a little bit of annoyance. So how do you start? And you're right when you say you start again with history. So in the history, the patient tells you she has a smelly discharge. It's grayish in color, but no associated symptoms, so no pain, pruritus, or soreness. It is sometimes worse after sexual intercourse or menstruation, she feels, and she noticed that it had a bit of a fishy smell. Examination, then, you look at the external genitalia, which are normal. Speculum examination shows a copious grey odorous discharge, but the cervix is normal. Have a look at this picture and think about a differential diagnosis to this scenario. And you're right, differential diagnosis could include Trichomonas vaginalis, as this also causes a similar discharge, but usually no smell. Treatment is with metronidazole. You give 2 grams of metronidazole as a start dose, and this is usually sufficient. You can also opt for 400 or 500 milligrams BD twice a day for 5 to 10 days. A one-off dose is usually preferable, as people are less likely, of course, to not complete the treatment. If it's taken all in one go, it's finished, and they do not have to remember it every day. So if you put them on a longer term treatment, 5 days, for example, after 3 days, she might have the discharge might have gone, and then she forgets taking her medication and complete the course. It is very important. Another form of treatment is topical treatment, which is a vaginal gel. This has to be given at night, so inserted in the vagina with an applicator 7 nights in a row, so 7 for a week. So this makes it a little bit complicated for women. So it does depend on what the patient prefers, if she prefers systematic treatment or topical treatment. There's a clindamycin gel, but there's also metronidazole topical treatments, and or there's not one treatment better than the other. Counseling is important in these cases. You have to explain to them that this is not a real infection. It's more of an imbalance in the vaginal flora with an overgrowth of anaerobe anaerobe bacteria over the normal lactobacilli of the vagina. And this, the patient has to understand how this is caused so that she can reduce recurrences. So you have to explain to her that frequent douching and so on is not kind of very, very good for the vaginal flora, that also wearing loose underwear is much better, and also cotton underwear should be preferred. So these are the points that you have to discuss with the patient. Let us go to case 3. This is a 72-year-old patient. She complains of discharge, which is yellow in color. In the history, she says she has had no bleeding. Her last menstrual period was 20 years ago, and she has had no history of postmenopausal bleeding. She also has no other associated symptoms. In the examination, there's a slightly small vaginal introitus with frail skin and a yellowy discharge, but it's not smelly. There's no odor associated with this. Okay, so what do you think could be the cause for this patient's problems? And you're absolutely right. As she says, denies any other symptoms, especially she denies bleeding. There's probably no reason to be too concerned about this, and this might just be a way of this might just be an expression of the genitourinary syndrome of the menopause due to a lack of estrogen in the tissues. It can be easily treated with estrogen cream, so topical estrogen kind of daily for 4 weeks, followed by 2 to 3 applications after that per week, so 2-3 applications per week afterwards. It can also be stopped afterwards to see how she is without this booster for her tissues. It is important in this patient to review her and arrange a follow-up, because you want to be sure that this kind of her symptoms settle down. If her symptoms do not settle down, she might require further investigations. This is especially important as she's an elderly patient lady who's at risk of other gynecological cancers. So case number 4 is a first-time mother who comes with her 1-week-old baby to see you because she saw some white discharge coming from her vagina. She had a normal delivery 1 week ago. No problem is known with the baby, and the neonatal examinations, everything was normal. On examination, also, you cannot find anything abnormal. It is a healthy baby with minimal discharge seen at the introitus. So this patient needs to be reassured because such kind of occurrences can be normal due to the influence of the estrogen on the kind of genitals of the baby. In fact, this is commonly kind of discussed in textbooks. In fact, this is probably very rare. Maybe it is rare because mothers kind of know, or people know about this being a possible cause, but it is a rare occurrence. It needs reassurance and nothing more. Case 5 is a 25-year-old patient who presents in her first pregnancy. She complains about a white, non-smelling discharge. So what do you do next? You expand her history. She denies any associated symptoms. She has no soreness, no pruritus. She's now in her 30th week pregnant, and she has had no problems in this pregnancy. Also, she has no other history, no other problems. What do you do next? In this case, what do you suspect we are dealing with here? This sounds as she has no associated symptoms, no other problems. this sounds like an increase, a normal increase in her vaginal discharge that pregnancy can bring about. You should not, if this is all, you should not need to examine her for this, as this causes might cause some discomfort and also some anxiety to patients, and might not actually be necessary. It is important to reassure her, explain to her this is probably a physiological increase in her discharge due to her pregnancy, but you have to safety net her. This means you have to tell her to return to see you if things kind of get worse, or if she develops any other symptoms, if she sees any blood or such like associated with this occurrence. It is, of course, very important to distinguish discharge from watery discharge, or watery loss, because you do not want to miss a spontaneous rupture of her membranes in this case. And if you have any suspicion or any evidence to think that this patient might actually mistake a watery loss or water loss, like amniotic fluid loss, with discharge, then you have to do an examination and take a swab, of course, at the same time. So you have to do a speculum examination to exclude or diagnose a premature pre-labor rupture of her membranes. But if this is not the case, if she's quite clear that this is discharge and she has no other surrounding associated symptoms, you can observe her. Now a mother comes to see you with a 6-year-old girl. She describes that she noticed a yellow staining in her pants and that the girl is itching quite a lot. What do you do next? Yes, you expand the history. She tells you it is not worse at night. She had never had it before, and she's otherwise a healthy girl with no diabetes or other disorder. That's right. You have to examine this patient just to by examining her abdomen to see that there's no pain, nothing, no other problems. Also, the bladder is not distended or anything. And also, you need to look at her external genitalia. There's no abdomen, is soft, not tender, there's no masses. You should look at her external genitalia to make sure it looks normal. It does look normal. So what differential diagnosis are we dealing with in this age group? So there can be a number of other differential diagnoses. Can be poor hygiene. Foreign bodies can sometimes be the cause of such discharge and problems. Threadworms or sexual abuse can also be a differential diagnosis. So in this case, so foreign bodies inserted in the vagina, this girl might be a little bit old for that, but you always have to consider it. They often also have some bloody discharge with it, but not always. So you have to make sure that you kind of consider that. Threadworms are a very common problem, and they are worse at night. So they cause itching mainly at night. And they can also cause such symptoms. They can also cause, typically they cause perianal itching, but they can sometimes also cause vulval and vaginal itching in children. And in this case, it was poor hygiene. This is a girl who kind of, a 5-year-old who will probably go to the toilet and look after her toilet needs on her own now, but might still not be that kind of good at cleaning herself. It is important that you discuss with the mother to clean with water after bowel movements, and initially she might want to help her daughter in doing so. It's important to clean from the front to the back, so to not take bacteria and dirt from the back passage, so from the perianal area to the vulva and vagina. To give this girl cotton underwear to wear and change it every day, and to avoid soaps in this area, but use water mainly. Now, a 76-year-old woman complains of blood-stained discharge for 1 month. This has got worse recently. So if you ask for the history, she will tell you that initially she only had a bit of kind of PV spotting. There she noticed a little bit of blood. She first ignored it, but recently it has got worse, and she actually is worried about this. Her last menstrual period is over 25 years ago, and she knows that it is not normal for her to have discharge blood, to see blood at this age. Investigation. Examination, you can actually not see, there's no active bleeding from the cervix, but you see that there was a bit of bleeding in the vagina, and otherwise it's normal. Investigations are very important here, mainly the transvaginal scan and also a pipelle biopsy. We have talked about pipelle biopsy in this context when we talked about perimenopausal bleeding. And a pipelle biopsy, as you know, is a device that can take an endometrial biopsy in the office. So you can combine a transvaginal scan looking for endometrial thickness, which should be below a cutoff of 4 millimeter, and you can combine this with a pipelle biopsy if needed, especially if the endometrial thickness is above 4 millimeter. In this patient, you are worried that she might have postmenopausal, that this patient presents, this is postmenopausal bleeding, and you are worried that she might have endometrial cancer, and to also cervical cancer is a possibility, and therefore an examination is also important to assess the cervix. Finally, we have a 46-year-old woman who comes to see you with a month-long history of increasing pain and green-yellow vaginal discharge. But for the last few days, she was feeling very unwell. She has been feverish and she just is not getting better. And now she also has pain across her abdomen, worse on the left, but it's all across her abdomen now. So what do you do next? You look at her history. She has no urinary and no bowel symptoms. She has reduced appetite but no vomiting. And her last menstrual period was 3 to 4 weeks ago. She doesn't exactly remember, but she uses condoms for contraception. In the past, she has had 2 normal vaginal deliveries. Laparotomy and drainage of a pelvic abscess was done once 4 years ago. Furthermore, she has been taking cyclical progesterones for menorrhagia. She's been taking the progesterone norethisterone to kind of regulate her kind of menstrual cycle a little bit and make it more manageable for her. And but she has no allergies and no other medical history. She is married and has only had this one partner. What do you do next? You have to do an examination. This patient is unwell, she's feverish. You have to start with the vital signs. In this case, she has a temperature of 37.8. Her heart rate is 95, and she has a blood pressure of 136/75. Very important to examine her abdomen and see where the tenderness is. So her abdomen is slightly distended with a kind of a little mass or fullness arising from the left. There's a localized pain in the left iliac fossa, but there's no rebound or guarding. Speculum examination shows no discharge or blood and a normal cervix. Pelvic examination, you find that there is cervical excitation, and you also find adnexal tenderness, which is worse on the left than the right. So what is your next step? What is the management of this patient? you have to do a beta HCG to exclude or diagnose pregnancy. In this case, her beta HCG is negative. You also have to take a full blood count and a CRP to look at and investigate this case further. So the hemoglobin is 10.3, her MCV is 91, she has white cell count of 13.8 and platelets of 521. The CRP is 95. So what do you do next? You do a vaginal ultrasound scan. This reveals this picture. You can see this is the left adnex, and there is kind of a little mass near the in the left adnex visible. And here's another picture of this mass. The U denotes the uterus, which looks kind of normal on this picture, but the arrows point towards an adnexal mass. What is the differential diagnosis? So this is most likely due to an infection. There's a mass in the left iliac fossa, which might be tubo-ovarian abscess, most likely due to an infection due to her associated symptoms. Sometimes it could also be a diverticular abscess, but in this age group this is less likely, and also if it was on the right, an appendicitis can also be a cause of this. An ovarian malignancy has to be considered, but is probably less likely as she presents with signs of infection, and also in the age group it's not that common to actually have ovarian malignancies yet. So how do you manage this patient now? First of all, I have another question. Why is she anemic? So she's anemic because she was treated, and she told you that in her history, that she was taking cyclical progesterones because she was having an irregular, and also before, prior to taking the medication, she had an irregular cycle which was associated with heavy bleeding. So she has a degree of menorrhagia, which makes her a little bit anemic. So it is important to admit this patient for IV antibiotics. You should follow your local protocol at the place where you work for treating this patient. This should include a combination of antibiotics that covers chlamydia, gonorrhea, broad spectrum, other vaginal commensals, as well as anaerobes. And it has to be given IV as she's kind of systemically ill. If there's no improvement with this treatment for 48 or 72 hours, you might need to do a laparoscopy for confirmation of your diagnosis, and also getting some tissue samples to kind of be able to deliver treatment to this patient which is specific for her infection. What further issues do you have? Often an organism, you find sometimes that there might be no organisms cultured in women with PID, and that is exactly the reason why, if they do not improve, you need to get some tissue, some culture, some samples for culture at the time of a laparoscopy to be sure to treat the right organisms. Often you find that PIDs, or pelvic inflammatory disease, is polymicrobial, caused by several different bacteria. It is important, though, in this patient to also screen for other sexually transmitted infections, as it might be due, she might also have other sexually transmitted infections, and this includes hepatitis B and C, HIV, and syphilis. Okay, this was our last case, and just to summarize this presentation, you have to have a systematic approach to these cases. Most commonly, discharge is physiological. Sometimes common causes are yeast infection, bacterial vaginitis, or trichomonas vaginalis. counseling and advice is very important, especially if there's recurring problems. And it's equally important to be able to recognize red flags. So in order to treat the serious conditions appropriately. Thank you very much for listening to this lecture. And we'll hear, I'll meet you for the next lecture.